Good afternoon. Welcome to the Fireside chat for the Tripledemic, RSV, flu, and COVID-19. For the first time, vaccines are now available to help protect against three major respiratory diseases: influenza or flu, COVID-19, and respiratory syncytial virus or RSV. But a new national survey by the National Foundation for Infectious Diseases found that many U.S. adults do not plan to take advantage of this and get vaccinated during the 2023-2024 respiratory season. Please join us now for a fireside chat from two of our top infectious disease specialists to learn more about these three important acute and contagious respiratory illnesses and what we can do to prevent them. I am Dr. Khadijah Lang, and I am the Region 6 Chair of the National Medical Association. I am a family physician in solo private practice, and I am a graduate of Fisk University, as well as the Charles Drew University of Science and Medicine program. I would like to go ahead and introduce our esteemed colleagues after reviewing the learning objectives that we have today. We would hope that at the end of this program, you will be able to examine why outbreaks of COVID-19, flu, and RSV created what is referred to as the triple threat. You should also be able to understand the recommendations for COVID-19, flu, and RSV vaccine for pregnant women, African Americans, and other vulnerable populations. Also, we hope you'll be able to demonstrate increased knowledge regarding the new seasonal trends related to COVID-19, flu, and RSV, as well as demonstrate increased competence related to patient family education about tripledemic vaccines. Also discuss with greater confidence their ability to prevent COVID-19, influenza, and RSV in patients, and effectively address vaccine hesitancy in African American patients and other peoples of color. Our first speaker for the National Medical Association's Tripledemic webinar is Dr. Dial Hewlett Jr. Dr. Hewlett is the Medical Director of Division of Disease Control and the Chief of Tuberculosis Services for the Westchester Department of Health. His bio is extensive, and he is not only an FACP and fellow of the American College of Physicians, but also fellow of the Infectious Disease Society of America. Dr. Hewlett has received his medical degree from the University of Wisconsin-Madison and is board certified in internal medicine as well as the subspecialty of infectious diseases. He served an internal medicine internship and residency at Harlem Hospital, Columbia University College of Physicians and Surgeons in New York City. He has a wealth of experience and expertise in the fields of infectious disease and was instrumental in controlling the COVID-19 pandemic when it first broke out in New York. Ladies and gentlemen, in the interest of time and the large amount of information available to be shared with you today, I am going to turn the speaker over to Dr. Hewlett so that he can begin working towards achieving our objectives for today. Dr. Hewlett?
Thank you so much, Dr. Lang, and good evening, good afternoon to everyone, and thank you for joining us. It's always an honor to be asked to share important information with our colleagues of the National Medical Association. I'm going to just give an overview, if you will, of influenza, and I will then turn things over to Dr. Kane, who's going to further discuss some of the vaccines and COVID. What I hope to do is to give you some high points of where we should be with influenza, which is totally preventable and a very important infection for us to consider. Now, influenza is an acute respiratory illness that's caused by either influenza A or influenza B viruses. It occurs in outbreaks and epidemics worldwide, mainly during the winter season, the season that we are now approaching. It's usually a self-limited infection. It is often associated, however, with increased morbidity and mortality in certain high-risk patient groups. Now, it's important for us to keep in mind the scope of this illness. And one of the things that we want to keep in mind is that this is preventable. This slide shows an estimated range of the annual burden of influenza in the United States between 2010 and 2020. There were probably anywhere between 9 million and 41 million cases of illness due to influenza A and B. There were probably about 140,000 to 710,000 hospitalizations. And unfortunately, there were probably about 12,000 to 52,000 deaths. And this is over the period of time, that 10-year period of time. Now, keep in mind that these deaths were mostly preventable. Not all of them could be prevented, but probably a lot of them could have been. Hospitalizations, probably a lot of these could have been prevented by the vaccine. And unfortunately, we as African Americans have some of the lowest rates of receiving the influenza vaccines. Now, the groups at highest risk for influenza complications include the following: children under 5 years, but especially those under 2 years. So I want to dispel some rumors and myths that children never get very sick from influenza. Children can become very sick and can become critically ill with influenza, especially those children under the age of 2. Adults 65 years of over also are at an increased risk for complications related to the flu. People who are pregnant or up to 2 weeks postpartum also are at high risk. So we want to make sure that our pregnant mothers are immunized. There is no contraindication to being immunized, and in fact, the College of OBGYN urges women who are pregnant to receive the influenza vaccine. Also at high risk are residents of nursing homes and long-term care facilities, and also, as we mentioned earlier, non-Hispanic Black persons, and also Hispanic or Latino persons, and indigenous individuals. Now, here are some of the facts about the influenza vaccination rates between 2009 to 2021. If we look at this cohort, which was reported by the Centers for Disease Control in 2022, they looked at 278,538 individuals. And in this cohort, those among the white population, 82.8% were vaccinated. Among the Hispanic population, 87% of this cohort of 214,307 were vaccinated, while among the African Americans, only 54.8% were vaccinated. And so as we look at this, it should become abundantly clear that a lot of the disparities here in the outcomes from influenza can be changed. And a lot of these outcomes and a lot of the disparities are due to the fact that we are not being vaccinated and we're not encouraging our population to be vaccinated. Now, influenza outcomes and pregnancy status and age. During the 2009 H1N1 pandemic, pregnant individuals accounted for 5% of all influenza deaths. Now, just think about that. These are all, of course, young women. This was totally preventable, yet they represented 5% of all of the influenza deaths back in 2009. Pregnant and recently postpartum patients within 2 weeks after delivery are at a moderate to increased risk for complications of influenza. And this has to do with the changes in physiology caused by pregnancy. It's also been estimated that the mean annual influenza-associated mortality rates were from 0.1 to 6.4 per 100,000 individuals among those less than 65, but from 2.9 to 44 per 100,000 among those 65 to 74 years of age. Influenza vaccine is indicated for all infants 6 months of age and older. So keep this in mind. Once they hit 6 months, they should be vaccinated for influenza. Children under 5 years are at a higher risk for developing influenza-related complications. And keep in mind that the bonus for the mother receiving influenza vaccine during pregnancy is that some of that protection will be passed along to the newborn during the first few months of life. The CDC encourages flu vaccines during pregnancy to protect the mother and the baby. Women who receive a flu vaccine during pregnancy had a lower risk of certain negative birth outcomes, including fetal death, stillbirth, preterm birth, and low birth weight infants. The CDC recommends flu vaccinations during pregnancy. Flu vaccine coverage among pregnant women in the United States has fallen 8 percentage points in the last 2 seasons, and this is really not good news, and it's even higher than that among African Americans. And so at this point, I will close and I will turn the meeting back over to Dr. Lang and to my colleague, Dr. Virginia Kane. Thank you very much.
Thank you very much, Dr. Hewlett. We appreciate that information that you just shared with us. And now it is my honor and privilege to bring to you our second speaker this evening, Dr. Virginia Kane. Dr. Kane is the Director and Chief Medical Officer of the Marion County Public Health Departments. She is an Associate Professor of Medicine at Indiana University School of Medicine Infectious Disease Division. She's served as, pardon me. I'm sorry, my screen is cutting off here. Okay, thank you, that's better. She has served as past president for the American Public Health Association, which is the nation's oldest and largest public health organization. She received the BioCrossroads 2017 August M. Watanabe Life Sciences Champion of the Year Awards in 2020, and the Indianapolis Business Journal named her one of the 40 influential people of the past 40 years as they celebrated 40 years of progress in Indianapolis. And she was awarded the Governor Holcomb's 2021 Circle of Corridon Award. Ladies and gentlemen, I would like to introduce you to Dr. Kane. Dr. Kane, welcome and thank you.
Thank you, Dr. Lane. If I could have my slides, let me see 1 second here. So, although the COVID pandemic, epidemic, no longer dominates a lot of our headlines, unfortunately, this pandemic has not ended. And we're now seeing, and we may have even the perfect storm coming now, where we have 3 of the most prominent acute respiratory illnesses that are so contagious that may occur at the same time. So I'm hoping to talk in my presentation today. I'm going to cover a little bit about what's happening with COVID-19, but also give an update on the newest vaccine that we have available for RSV. So I'll first start out by talking a little bit about the respiratory syncytial virus, RSV, which causes a respiratory illness very similar to COVID-19 and very similar to the flu, and now occurs in most regions of the United States and circulates primarily during the fall, winter, and spring. And although we mostly recognize it as one of the most common causes of childhood illness, it has also been noted to be a common cause of acute respiratory illness in older adults because of its contagiousness. And RSV typically causes mild cold-like symptoms in adults initially starting out, but it can lead to more serious conditions and death in our older adults, and particularly those who have a weakened immune system. And one thing that's very similar with RSV, like we see with COVID-19, is that you can transmit this virus maybe even 1 to 2 days before you develop symptoms related to RSV. We know that there are about 60 to 160,000 adults over the age of 65 who are hospitalized due to RSV. So you can see it hits the very young, our young children, but our seniors, with about 10,000 deaths occurring from RSV annually. But among our children younger than age 5, we have about 58,000 to 80,000 hospitalizations occur every year. But we have about 2.1 million outpatient visits for children under 5 associated with this RSV infection. So we're happy to say that this year, the U.S. Food and Drug Administration has approved the first 2 vaccines for adults for the prevention of RSV, which is now recommended by the Centers for Disease Control for this upcoming 2023-2024 respiratory virus season. And these vaccines are approved by the FDA as a single dose for adults age 60 years or older for the prevention of RSV. And a lot of times this involves maybe having shared clinical decision-making with your patients. Now, the risk of the severe RSV disease increases the older you get, and with other underlying chronic conditions such as asthma, congestive heart failure, or COPD. And we have persons that have other underlying factors or conditions that the provider may determine might increase their risk for severe respiratory disease, maybe a chronic smoker for a number of years. And also, probably the most important thing is we have found that one of the vaccines is approved for patients who are pregnant to help prevent RSV infection in infants born to those who are vaccinated during their pregnancy. And remember, this vaccine, we suggest that maybe there may be some maternal antibodies developed from this vaccine in the pregnant mother to her newborn baby in the first 6 months. And so this vaccine should be given between weeks 32 and week 36 of their pregnancy. And it's been found that the effectiveness of this vaccine is 83 to 89% effective, depending on which of the vaccines you receive. Now I'm going to move on to COVID-19. And as you can see, basically on the slide, it may be a little difficult to see from the end, but COVID-19 is that very orange number of cases. So if you go back to October of last year and where we were seeing a big increase of cases in the emergency room visits, with the combined visits almost making up 10% of the ER visits in our hospitals by the end of the November Thanksgiving kind of holidays going into the early December, with the most cases seen by our influenza cases at about 6% of these visits, followed by the COVID-19 cases, and then at that time, a very low RSV. Now, similar, we're going to wait to see whether we will have the same rise of activity in our 3 major respiratory illnesses this year, though it appears though it may be a little bit more milder than what we saw last year. And this map just highlights back in March, when you can see all these daily cases, the red of these dots were, just look at the enormous amount of COVID hotspots that occurred back in March in regards to the COVID-19. But now, if we look at the reported COVID-19 new hospital admissions up through up through October the 3rd of this year, you will see that there's very few low COVID-19 hospital admissions occurring now, except for very few pockets right here, a little bit in Ohio. And you can see up there in some of the Idaho has some cases. It looks like Michigan has some high activity, Nevada with some high activity. But overall, the transmission of COVID-19 is remaining low in a number of places, with a few medium activities taking place for the COVID-19 hospital admissions. But I want to remind folks that we found during this epidemic that the people of the color were the hardest hit, and where we saw our Blacks having 2.5 the hospitalizations, our Hispanic, our Latinos 2.4 times hospitalizations compared to their white counterparts, and our American Indian or Alaska Native at 3.2 times the number of hospitalizations compared to our white counterparts, associated with nearly twice the death rates compared to our white counterparts, with our Asian non-Hispanic persons having the lowest number of cases and having the lowest number of hospitalizations associated with the lowest number of deaths. And so one of the major reasons associated with that was based on the amount of vaccinations in the different racial and ethnic populations, with the highest back in July the 11th of a race receiving at least one COVID-19 vaccine dose. We had the Asian population having at least 87% had received at least one COVID-19 vaccine dose, followed by the Hispanic population at 67%, and our white population at 64%, with our Black racial group with the lowest vaccination rate at 59%. But if you will look at our most recent data, let's see, I think there's a slide is skipping. Here we go. When we look at up through May the 10th, 23rd, this slide highlights the fact that, and it may be a little bit difficult to see from far off, but for those who actually completed their primary series of the vaccines, the highest rate was our Asian population at 65%, at the highest rate of vaccination, followed by our Hawaiian population at 65%. Next, followed by our Latino population at 57%, and our white population at 52%, who had completed the primary series for vaccinations, with Blacks being the lowest at 45%. But when we are kicking off our updated bivalent booster doses, you will see in that 3-year period that both the Black and Latino populations had less than 10% had received a booster dose. And so making it that we have a lot of our work still cut out for us in terms of how we address vaccine hesitancy, how we address access to be able to get access to these vaccines and other barriers facing folks. So when we look at the COVID-19 booster vaccine recommendations, because the older bivalent vaccines covered the Omicron variant, but it didn't cover the newer variants from Omicron that has occurred, we now have a new booster, specially formulated vaccine that is available. And so the recommendation now is we're having it be offered sort of like as a seasonal vaccine, just like the flu, where you're able to now get it, maybe we're hoping once a year. So if you've never been vaccinated at all with regard to COVID-19, and you're not moderately or severely immunocompromised, then you will receive 1 dose of the specially formula vaccine by Moderna, or you will receive 1 dose of the specially vaccine formulated by Pfizer. And if you have Novavax, you must receive at least 2 doses, and they have to be these 2 doses at least 3 to 5 weeks apart. Now, if you'd already been vaccinated before in the past, and you've received at least one of the messenger RNA vaccines, which is Moderna and Pfizer, then you only have to get one dose of Moderna, or you only have to get 1 dose now of Novavax, or 1 dose of Pfizer, in terms of the updated recommendations from ACIP and CDC in terms of being protected going into this fall, winter months. But if you are moderately or severely compromised, let's say you're on active treatment for solid tumor or hematologic malignancies. For example, you may have multiple myeloma, acute leukemia, or you may have non-Hodgkin's lymphoma, or you've recently undergone a solid organ transplant, like a kidney transplant or whatever, or you're on special immunosuppressive therapy like CAR T-cell therapy, or you may have a severe primary immunodeficiency, or you're HIV infected, but you have an advanced HIV infection where your CD4 count is less than 200 cells, and you have a history of an AIDS-defining illness or clinical manifestations of a symptomatic HIV, or sometimes we have other conditions where you may be on high-dose steroids for certain rheumatologic conditions. And so these individuals, if you have a moderately or severely immunocompromised, then if you've been unvaccinated, the recommendations, you've never received a vaccine of any of these COVID-19 vaccines, the recommendation is that you get at least 3 doses of Moderna, or 2 doses separated by Novavax, or you get at least 3 doses of Pfizer, which are the messenger RNA vaccines. But if you've ever been vaccinated, then you can only need to receive 1 dose of Moderna, or 2 doses of Moderna. Oops, sorry about that. Or if you're vaccinated, you get 1 dose of Pfizer and then 2 doses of the Pfizer vaccine. And so you need to have at least 3 or more doses of any messenger RNA vaccine if you've been moderately or severely immunocompromised. And if you were Novavax, you get at least 1 more dose. And so I just also want to remind you that if you're pregnant, we know that pregnant women who become infected with COVID-19 as infection has more severe complications if they've never been vaccinated. So strongly encourage any pregnant mother to get that COVID-19 vaccine. And so thank you very much.
Okay. Thank you very much, Dr. Kane. And we have a couple of questions in the queue. The first one is, if a patient has COVID and has no taste issues, takes the Paxlovid treatment, then develops a bitter taste lasting 6 to 7 weeks, usually when will it go away? Is that bitter taste coming, the question is that bitter taste coming from the Paxlovid or from the inflammation due to COVID causing the problem?
So I'll let Dr. Dow answer that question, but I'm sure he's going to tell you
Okay.
that the bitter taste is coming from the Paxlovid.
Well, that's an interesting question. We know from those who have taken Paxlovid that it does have a bitter taste. But by the same token, one of the things that we also know about the loss of taste and smell that results from COVID is that it can cause a variety of disturbances with our taste. It can cause a condition we call taste perversion. And so some individuals have reported the persistence of a bitter taste, and this has occurred without even being exposed to the Paxlovid. So I would venture to think or to guess that it is more likely due to essentially a complication of long COVID. And unfortunately, we know that this is something that can take a very long time to resolve. One of the things that we are urging our patients to do, and we're trying to help them, is to locate centers of excellence that are actually managing patients with long COVID. And there are some specific therapies that people are going through to try to overcome problems related to taste and smell loss.
Thank you, Dr. Hewlett. The next question that we have is, how long should a person wait, a patient wait, to get a COVID booster after they have been infected with COVID?
So it's still 3 months, basically, if they've had the actual COVID infection recently, so that it's most likely they're going to get the COVID infection that's the circulating variant that's going around in the community, so that they'll have that immunity for about 3 months. But then they really need to, after that, get that COVID-19 booster.
Thank you. And we have another question, which is, this questionnaire is asking, what is the quarantine period after COVID? So once a person has been infected with COVID, and I would add to that, in contact with someone who has tested positive for COVID, how long should a person quarantine?
So normally once you've gotten a recent COVID infection, they can say that on your 6th day of the infection, if you test negative, you don't have to be quarantined, but you must continue to wear a mask from 6 to 10 days after your quarantine, only if you test negative on the 6th day, not the 5th day. Thal, do you want to add anything else to that?
No, I can't add anything else, Dr. King.
The second part of that question, well, I would also add to that. I asked about people who are in communication with that. So one person gets it, the spouse or family member that's in the household with it, do they need to quarantine as well, or is it just if they test negative, or just the patient who actually tests positive that should be quarantining?
So that's a little, I'll let Dal pipe in too, but that's a little trickier question. And I say that because if you have someone that's positive in the household, and you might have like a baby in the house, or you may have someone that's moderately or severely immunocompromised, if you can and you're able to do it inside the house, you want to do social distancing if they have not yet become infected. And you also have to remember now, you can have people who are positive for COVID-19 and they have no symptoms whatsoever. So you do need to make sure you're testing everybody if someone's positive in that household, to just make sure that someone may be unaware that they're infected, and depending on what their lifestyle is, you don't want them going to like a daycare or, hospital setting or school setting and might not be aware that you're infected. Yes, Dow.
Yeah, this has been a dilemma for us in our health department. And I know that during this second wave, we have actually been a bit less, I guess you would say, diligent in terms of the quarantine. And one of the things that's been brought to our attention is, yes, it's important for us to make sure that infection is not transmitted. One of the things that we know is that some people remain positive for prolonged periods of time. And so we have to try to use some clinical judgment as well, because there are obvious disruptions to a person's occupation, to their education. Also, if the children have to be at home for prolonged periods of time, this disrupts the activities of the parents. And so this is sort of an ongoing discussion. I certainly agree, though, we can't be cavalier about it. But I think that at this point in time, since we know a little bit more than we knew previously, we can try to provide guidance for our patients. And this is one of the places where I think that our primary physicians can play a role, as well as those of us who are in the health departments.
And as primary care physicians, should we be advising those household members that are testing negative but have been in contact with the patient that's positive in the house to also refrain from going to work, or just wear a mask when they go out if they're negative?
So we don't stop them from going to work if they're negative.
Okay.
Or whatever, but we just need them to be conscious of that and be aware if they should develop some symptoms, and I got an allergy, but they may have that nasal congestion, sore throat, and they may be coughing. And so, and you have someone that's positive in your household, you have to be concerned that you may have become infected. But as long as you're negative, you've tested yourself and you're negative, we don't prevent you from going to work.
Great, thank you. Our next question has to do with exercise protocol that can be suggested after COVID.
That's a tough question, but I think we all, just from the standpoint of general medicine, encourage people to try to resume exercise. Now, with that said, we know for a fact that some people who have had severe cases of COVID may actually have inflammation of their lungs that might prevent them from exercising vigorously, and that in some situations we've actually had people undergo pulmonary consultations where they've actually had to be treated with anti-inflammatory medications. We know that there are some people who have symptoms that are associated with joint pain, and that the mobility is limited by that. But I think that we encourage people to be active, and I think that in the programs that are ongoing right now, that's one of the things that people are doing, trying to control the symptoms with relatively benign medications like non-steroidal anti-inflammatory medications.
Okay, thank you. We have another question, and that is, how as providers do you address the vaccine hesitancy as well as misinformation that is surrounding the COVID-19 vaccines as well as other vaccines?
I can say one thing about that, then I'll turn it over to Dr. Kane.
Okay.
One of the lessons that we learned was it's very important for us to listen. And so before we tell people that they're foolish or that they're crazy, we have to listen. to why it is that they feel that they don't want to be vaccinated, and try to understand sort of on what basis they are working in terms of why they don't want to be vaccinated, and to try to make them understand and to feel that we feel that the way that they are feeling is important. So that's one of the first things that I would advise for any physician who is faced with patients who don't want to be vaccinated. I think the second thing is to point to them the obvious fact that people who are vaccinated are much less likely to be hospitalized, much less likely to die. That's just a fact. And I think that some of the figures which Dr. Kane shared can be very effective in doing that.
So actually, I think one of the key things is that, you know, some people believe because they've had an infection, sometimes it's just the misinformation that once they've had a COVID-19 infection, that they never have to worry about being vaccinated ever, that they believe they have a lifelong immunity, and so they don't realize that it can come back. So that's one of the first issues in trying to educate them in relation to that. I think the other thing that I see, especially with my younger patients and my male patients who are younger, that they think they're invincible, they're healthy, they never get sick, so they don't see the need to get the vaccine. And yet we cannot ignore the fact of long COVID, where you can get long COVID and have these chronic symptoms. And wow, don't get that chronic fatigue syndrome that can last not just months, but it can last years, where you're so tired, you might only have 1 good hour or 2 hours out of the day, and you just feel exhausted all the time. Or you can have chronic headaches. You can have chronic heart palpitations that you might not have never had before, chronic shortness of breath. And Lord, you know, you say, oh, I must be getting older because now my joints and everything is aching all over the place and whatever. And my knees are killing me, my elbows, my shoulders, what's going on? So we have to explain to them that you can be at risk for this long COVID. But I also emphasize the fact that, you know, if not for yourself, think about your loved ones and your colleagues. You may have a baby in your house, and I'm not worried about you, but I want you to protect that baby. Or your mother, your grandmother may be in the house, and they have a little bit more weakened immune system, so they can't afford to get an infection from you. So I think when you have to take the time to explain this, but it is hard for us providers, because we don't get reimbursed from this. And you think you can get away with discussing this in 15 minutes for them to understand about the vaccine, the safety profile. You know, we hear about sometimes the myocarditis and pericarditis that can be associated with our younger Black males at a certain age, related to some of our older vaccines. And so you just have to really address their concerns, okay?
One other thing I would interject, Dr. Lang and Dr. Kane, is that even if the person rejects your recommendation to receive the vaccination, try to offer them something else that might be of value to them. You know, we say to our young people and older people as well, you know, diabetes is something that will actually cause greater harm if you get COVID. And so at least let us control your diabetes, you know, heart disease and hypertension, excessive weight. Why don't you let us get you into a weight control program? Or if they smoke, why don't you let us work on your smoking? So let's see if we can offer them something else that might be more acceptable to them, that is going to favorably impact upon their overall health.
Great. Thank you both for that. The next question is, do any of the 3 vaccines discussed today, or are any of the 3 vaccines discussed today capable of actually causing the patient to get that disease?
So none of these vaccines, none of these vaccines are made with live virus. And they're so weakened and everything. None of these 3 vaccines, whether it's RSV, whether it's COVID-19 or influenza, can actually cause the disease because they're not live vaccines.
Right.
What they do is they have a substance that's introduced as a protein that's introduced into your body that your body thinks is a foreign process or something. And so your body's immune system responds by developing antibodies against this. So when the real virus comes, it already has had antibodies that have been developed, and normally takes about 2 to 3 weeks to get those antibodies in your system, because some people think once I get that vaccine, I'm immediately protected. No, you're not. It's going to take about 2 to 3 weeks for your body to develop these antibodies and special other cells to protect them in the immune system. But it does not cause disease whatsoever.
Great.
One thing which everyone should be aware of, though, is that most of us, after we receive the vaccine, maybe a day or so later, may actually experience some chills, or some people may get mild fever. They may feel a little bit tired. And that is what we call the immunogenicity. That's actually, as Dr. Kane said, your immune system is working, and it's basically having that battle within you, essentially conditioning your immune system so that when the real virus does come, you're ready to go. So just keep that in mind, that you may have a day or a day and a half of some discomfort after you get that vaccine, but then it goes away very, very rapidly.
And the key thing is it may not prevent infection, but what it can do, it's that it can prevent you from having a severe form of the infection. So it can prevent you from having to develop that infection where it's severe enough for you to be hospitalized, or severe enough for you to end up in the intensive care unit where you're on a respirator. And so if it can do that, present over like 90% of that happening, that is a wonderful scientific tool in order to save lives.
Yeah.
Listen, everybody understands about needing a blood transfusion if you're in an accident and you're starting to bleed, or you may be in surgery and your hematocrit's dropping. Everyone understands about blood transfusions, right? So we have the famous Dr. Charles Drew back in World War II, who understood about blood transfusions, did that research, and understood that plasma could save lives. We have a lot of our Black scientists, our Black doctors that have been doing this research because they're public servants. They want to improve the lives of the people from our communities because they live and reside in those communities. And so know that we've got some talent. That young researcher, physician who helped to develop the Moderna vaccine, just incredible. Started out in high school doing an internship at NIH, and eventually worked and developed her, got her PhD, became very prominent at NIH. And so we've got some very smart people, scientists, PhDs, who work constantly on improving our lives.
Great, thank you. We have another question, and that question is it okay for a person to take RSV and COVID vaccines being administered at the same time? And if not, what is the time gap in between that one should wait?
Now, someone, go and talk about that. I'll let you say first, okay?
The
I'm
public
opinionated,
health,
so go on, okay.
okay, the public health axiom is that when you have the person in front of you, and they want to have the vaccines. You try to give them whatever is indicated, as well as whatever they're willing to take. And so we have been told, at least, that it is fine to give both of them at the same time. We know that there can be some drawbacks in that a person is more likely to have more of a immunogenic response, if you will. But we do think that if someone is willing to take both together, that they should be allowed to do so. There's often some concern about if you give two vaccines at the same time, it's more difficult for the immune system to have the same kind of a response as if the vaccines were given separately.
Thank you. We have another question, and that is, how is the efficacy of COVID vaccine in younger population, i.e. patients under 5 years old?
Very, very effective. I know that there were studies that were done before the vaccine was approved, in both of the mRNA vaccines, and they were shown to be very effective. And it was not only based upon how well they would prevent hospitalization and death in infants, but by the responses. That is, in the studies, they actually did measure what they call the immunogenic response. They quantified that, and they had correlates with what actually would correlate with protection. And they were able to show that the infants were able to have at levels that would be considered equivalent for protection.
Thank you. We have another question, which is, again, spacing of vaccines, and that is, how long should one wait to get a shingles vaccine after having had a COVID booster?
So I think that's at least a minimum of 2 weeks before you can get a shingle vaccine if you've received a COVID-19 vaccine, and some people prefer really 4 weeks because it takes how long. You don't want to get one vaccine that sometimes may interfere with the other one. I think for the shingles, though, it's at least a minimum of 2 weeks, where that's one that you don't want to give together.
Thank you. Another question is, if a patient receives the COVID vaccine and within 48 hours develops symptoms consistent with COVID, if they test themselves and they test positive for COVID, do they assume that they in fact did catch COVID in the midst of getting their vaccine, or that this is a response of the vaccine?
It's more likely than not that they had COVID at the time that they received the vaccine, and they were in that asymptomatic window phase, because we know that many people who develop COVID have the actual infection, and if you actually were to do the testing, they actually have the virus for a couple of days before they develop symptoms. So that would be the most likely response or explanation for that.
And that person would then quarantine and isolate as if they had not had a vaccine.
Yes, unfortunately.
Okay, thank you. Dr. Kane, did you want to add anything to that?
No, I'm good.
Okay. We have, let's see if there's any more questions in the chat. It appears that you have done a fabulous job of responding to all of the questions that have been submitted. If anyone has any last questions they would like to submit, please submit them now to the chat box, and I will pose them to our presenters.
And I would like to just put in a plug, since I'm now for multiple times a grandparent.
Congratulations.
We are not doing very well in getting our children vaccinated, our infants vaccinated, and our infants are very vulnerable, as Dr. Kane stated. And so we need to encourage our patients to make sure that they're protecting their infants by having the infants vaccinated, having the pregnant mothers vaccinated. I have a daughter-in-law who I'm trying to convince her to be immunized, and also to emphasize, as Dr. Kane said, that you're not just taking the vaccine for yourself. but you are also taking the vaccine to protect the people who are in your surroundings and in your household. So I'll just put in a plug for that.
Thank you. Dr. Kane, as we bring the program to the end, would you like to give us some closing comments or words of wisdom?
Well, I think one of the things that we've got to understand that, we're now going into this new era. We had that policy of, shots in all arms. So the government provided all the COVID-19 vaccine when we were having this big pandemic, get these shots in the arms. And our COVID vaccines, we saved at least 3 million lives, but we kept more than about 18.5 million individuals out of the hospital. And that's been since just December 2021. So that's been critical. But now that we're losing that emergency authorization, a lot of people are going to be falling off the insurance. We estimated that maybe 25 to 30 million folks will lose their insurance now because we don't no longer have that emergency authorization. That the CDC has launched what we call the Bridge Access Program. For a lot of our people, because of the poverty levels, lack of insurance, don't have providers, this Bridge Access Program is going to provide free COVID vaccines to the uninsured and underinsured adults, just like our vaccine for children. This is similar to a vaccine for adults, where you can get these free vaccines either at the pharmacy retailers or federally qualified community health centers or health departments. So look to refer for the folks who don't have insurance or can't afford these vaccines, because these vaccines now are going to be over $100. So make sure you refer them to the providers who are working with Vaccine for Adults programs. And we want to encourage any provider, please contact your health department and see if you want to be a provider in order to provide these vaccines for your patients.
And Dr. Kane, would you be able to tell those physicians listening what the reimbursement would be if they do, those that are in private practice, if they were to join in this program and offer to immunize patients through this program?
So I don't know what the actual reimbursement is, but I know that they tried to do the reimbursement higher at the Medicare level as opposed to the Medicaid reimbursements that we normally see. So trying to entice and encourage more providers to participate. So,
and do those providers have to purchase the immunizations
no,
first?
no, the vaccines are provided free of charge
And then
by the health departments.
The actual,
so they have to sign like an agreement with the health department. We have to go in and make sure that you got the right refrigerator and things in your office, but we provide the vaccines free from health departments to the providers who participate on this program. We already have it for vaccines for children, but we don't have it for vaccines for adults. That program so far is sort of in limbo, and we're hoping that the Centers for Disease Control's funding will be available in order to get that implemented. But otherwise, we do have the CDC Bridge Access Program that's designed to help that out. But one important point that we just have to emphasize, the most trusted messenger for patients in the poll has highlighted is the healthcare professional. We are the most trusted source for information. 75% of the public believes that we are the most trusted source for medical information. But we have to educate our providers and we have to educate our patients related to the vaccine information. And don't forget, there's simple other tips you can have. If you're sick, stay at home. You know, if you're coughing or sneezing, you know, you can pull that elbow up there and cover your nose and mouth. Wash your hands frequently. Keep your environment clean, you know, with hygiene. And do you know that the poll stated that more Blacks are willing to wear masks in their doctor's office compared to Latinos or other white patients? So we want to do those things that will safeguard ourselves. And I think if we just continue those standard practices, those simple tips, it'll make you a lot safer and have a healthier outcome.
Thank you, Dr. Kane. Dr. Hewlett, did you have any final pearls of wisdom you'd like to share with us as we wrap up the program?
Nothing else. I think that Dr. Kane said it all. So I echo all of her comments.
Okay, well, in that case, it is 8:02 Eastern Time. I would like to thank, on behalf of the National Medical Association, I would like to extend our appreciation to Dr. Shonda Holsey, the chair of the Internal Medicine Division, who made it possible for us to put this webinar on. I thank all of the participants that joined us. I don't know, perhaps Solomon, you can answer, is this going to be an enduring program that people can go back and watch? I know here I'm on the West Coast in California. I know many people are still seeing patients right now. And for those people that were not able to be on at the time live, will they be able to watch it at a later time? He's muted, so I don't know if he can respond to us.
So my understanding is that yes, that we were hoping to have this webinar available for other people to be able to get a chance to look at it. If you didn't get all the details, come back and listen to us again.
Okay. Yes. And he has confirmed that yes, it will be available. Dr. Hewlett, were you going to say something else?
No.
Okay. Okay, so to the attendees, I thank you all for attending. Please spread the information that you gained today here, and please let others that were not able to attend live share with them the fact that this will be available for continued viewing later for whoever could not view it at this time. And with that, I will close out. I will thank you all for your participation, and great seeing everybody. And have a wonderful, safe weekend.